Welcome back to another Sleepy Steve story. Before we drift off tonight, remember to subscribe to help Steve-O out, and I will keep making more sleepy stories to help you study gently, revise quietly, and settle your mind at the end of the day. Let us settle into Unit 3 of Health and Human Development, and let us keep our focus gentle, clear, and steady. Tonight, we are looking at Australia's health status, not just what health and well-being means, because we have already begun that journey, but how we measure it, how we describe it, how we compare it, and how we use evidence to understand whether a population is living long lives, healthy lives, supported lives, or lives affected by illness, injury, disease, and inequality. So, take a slow breath in and let it go. In VCE Health and Human Development, health status refers to the overall level of health and well-being of an individual or a population, taking into account measures such as life expectancy, mortality, morbidity, and burden of disease. That sounds technical at first, but the idea is simple. Health status is the picture we build when we use data to understand how healthy a person, group, or population is. If health and well-being is the lived experience, then health status is one way of measuring that experience. It is not perfect, because numbers cannot tell us everything about someone's physical, social, emotional, mental, or spiritual health and well-being. But numbers can help us notice patterns. They can help us ask better questions. They can help governments, communities, schools, health services, and individuals decide where support is most needed. So tonight, we will move calmly through the main indicators: life expectancy, health-adjusted life expectancy, mortality, morbidity, burden of disease, and then we will gently think about trends in Australia's health status and how students can use data in exam responses without becoming lost in the numbers. Let us begin with life expectancy. Life expectancy is the number of years a person can expect to live, usually if current death rates continue throughout their lifetime. When a country has a high life expectancy, it generally suggests that many people have access to factors that support health and well-being, such as healthcare, safe water, nutritious food, education, income, housing, immunization, disease prevention, and social support. Australia is generally considered to have a high life expectancy compared with many countries around the world. This reflects, in broad terms, Australia's relatively strong health system, high standard of living, access to clean water and sanitation, food security, public health measures, education, and medical technology. But life expectancy does not tell the whole story. A person might live for many years, but not all of those years may be lived in good health. This is where health-adjusted life expectancy becomes important. Health-adjusted life expectancy, often called HALE, is a measure that adjusts life expectancy by taking into account the time a person is expected to live in full health. In simple terms, it asks not only how long people are living, but how many of those years are likely to be healthy years. This is important in health and human development because we are not only interested in surviving, we are interested in living with energy, connection, independence, purpose, and well-being. For example, if two populations have similar life expectancy, but one population experiences more years living with chronic disease, disability, pain, mental illness, or reduced independence, then their health-adjusted life expectancy may be lower. That tells us something important. It tells us that length of life and quality of life are connected, but they are not the same thing. Now let us move to mortality. Mortality refers to death. Mortality data tells us about the number of deaths in a population, or the rate at which deaths occur. In HHD, we might look at mortality rates, infant mortality rates, under 5 mortality rates, maternal mortality rates, or deaths from particular causes such as cardiovascular disease, cancer, injury, respiratory disease, or diabetes. When we look at mortality in Australia, we are often looking for patterns. Which causes of death are most common? Which groups are more likely to experience premature death? Are death rates improving over time? Are some causes of death becoming less common because of public health action, medical treatment, or behavior change? Mortality data can reveal both success and concern. For example, if fewer people are dying from certain infectious diseases over time, that may reflect immunization, sanitation, antibiotics, public health surveillance, and better health care. If deaths from chronic diseases remain high, that may suggest the ongoing importance of prevention, early detection, treatment, lifestyle factors, social determinants, and access to care. A very useful exam habit is to remember that mortality data shows death, but it does not show all illness. That is where morbidity comes in. Morbidity refers to ill health in an individual or population. It includes disease, illness, injury, disability, and poor mental health. Morbidity data might include the prevalence of asthma, the incidence of cancer, rates of diabetes, mental health conditions, hospital admissions, injury rates, or the proportion of people living with disability. Prevalence and incidence are words students sometimes mix up, so let us pause there. Prevalence refers to the total number or proportion of cases of a condition in a population at a particular time. Incidence refers to the number or rate of new cases of a condition occurring during a particular period. So, if we were thinking about a health condition, prevalence tells us how widespread it is overall, while incidence tells us how many new cases are occurring. Both can be useful. A high prevalence of a condition may suggest a large number of people need ongoing support. A rising incidence may suggest more people are developing the condition, which may signal emerging risk factors or the need for prevention. Morbidity is especially important because many of Australia's major health concerns are chronic conditions. A chronic condition is generally long-lasting and may require ongoing management. Examples include cardiovascular disease, cancer, diabetes, asthma, arthritis, chronic kidney disease, and mental health conditions. These conditions can affect physical health and well-being by causing pain, fatigue, reduced mobility, reduced immune function, or reduced capacity to complete daily activities. They can affect mental health and well-being by increasing stress, anxiety, low mood, or reduced sense of control. They can affect social health and well-being if a person finds it harder to participate in work, school, family life, or community activities. They can affect emotional health and well-being through frustration, fear, sadness, or uncertainty. And they can affect spiritual health and well-being if a person feels disconnected from meaning, belonging, values, identity, or purpose. That is why HHD constantly asks us to link data back to the dimensions of health and well-being. A number is never just a number. It is evidence of lived experience. Now let us consider burden of disease. Burden of disease is a measure of the impact of disease and injury on a population. It combines the impact of premature death with the impact of living with illness, injury, or disability. The common measure used is the DALY, which stands for Disability Adjusted Life Year. One DALY represents 1 year of healthy life lost due to illness, injury, disability, or premature death. There are 2 parts to burden of disease. YLL, or years of life lost, measures the fatal burden. That means the years lost because people die earlier than expected. YLD, or years lived with disability, measures the non-fatal burden. That means the years lived with illness, injury, or reduced functioning. Together, YLL and YLD make up the total burden of disease. This is a powerful idea because some conditions cause a great deal of death, while others may not cause as many deaths, but can cause many years of illness or reduced quality of life. For example, a condition that causes long-term pain or mental illness may contribute strongly to non-fatal burden, even if it is not always a leading cause of death. A condition that causes premature death may contribute strongly to fatal burden. When students understand burden of disease, they can explain health status more deeply. They can say not only that a condition is common, but that it contributes to lost healthy years. They can say not only that people are living longer, but that some people are living with significant non-fatal burden. And they can connect this to health and well-being by explaining how illness and injury can limit independence, participation, functioning, connection, and quality of life. Now let us think about Australia's overall health status. In broad terms, Australia has a relatively high health status compared with many nations. People in Australia generally have high life expectancy, access to a developed healthcare system, widespread immunization, safe water and sanitation, public health regulation, food safety systems, and relatively high levels of education and income. But Australia's health status is not perfect, and it is not equal for everyone. There are still major concerns. Chronic disease contributes heavily to morbidity and burden of disease. Mental health conditions affect many people across the lifespan, including young people and adults. Lifestyle-related risk factors such as tobacco use, harmful alcohol use, poor nutrition, physical inactivity, and overweight or obesity can increase the risk of chronic conditions. Environmental factors such as air quality, climate change, housing conditions, and access to green space can also influence health and well-being. And socio-cultural factors such as income, education, employment, social exclusion, discrimination, culture, gender, access to services, and experiences of racism can contribute to variations in health status. This matters because health and human development is not only about averages, it is about variation. A national average can make a population look healthy overall while hiding differences between groups. For example, different population groups may experience different levels of life expectancy, morbidity, mortality, and burden of disease due to unequal access to the resources required for health and well-being. This includes access to culturally safe healthcare, education, employment, stable housing, transport, nutritious food, safe environments, and social support. When you see a health status data question in an assessment, the first step is not to panic. The first step is to read the title, the labels, and the units. Ask yourself, what is being measured? Is it life expectancy, mortality, morbidity, burden of disease, prevalence, incidence, or something else? Then ask, who is being compared? Is it males and females, different age groups, different states or territories, different socioeconomic groups, Aboriginal and Torres Strait Islander peoples and non-Indigenous Australians, Australia and another country? Then ask, what is the pattern? Is one group higher or lower? Is the rate increasing or decreasing over time? Is the gap widening, narrowing, or staying about the same? Then, once you have described the data, you can interpret it. This means explaining what the data suggests about health status and health and well-being. For example, if a group has a higher rate of mortality from a particular condition, this suggests poorer health status in relation to that cause of death, and may indicate a need for prevention, early detection, treatment, improved access, or targeted support. If a group has a higher burden of disease, this suggests more healthy years are being lost due to illness, injury, disability, or premature death. If life expectancy is increasing, this may suggest improvements in medical care, public health, living conditions, or health behaviors, but students should still consider whether those extra years are being lived in full health. A strong HHD answer does three things. It uses the data accurately, it uses the correct health status indicator, and it links the indicator back to health and well-being. Let us practice that softly. Instead of saying, the data is bad, we might say, the higher mortality rate suggests that this group is experiencing poorer health status because more people are dying from this condition. Instead of saying they are unhealthy, we might say, the higher burden of disease suggests that more healthy years are being lost due to illness, disability, or premature death, which may reduce physical, mental, and social health and well-being. Instead of saying, Australia is good, we might say, Australia's high life expectancy suggests strong overall health status compared with many countries, but this does not show whether all groups experience the same level of health and well-being. Notice how calm and precise that language is. It does not overstate. It does not guess beyond the data. It explains what the indicator means. Now let us return to the key indicators one last time, almost like we are placing them in a row on a quiet desk. Life expectancy tells us how long people are expected to live. Health-adjusted life expectancy tells us how many years people are expected to live in full health. Mortality tells us about death. Morbidity tells us about illness, injury, and disease. Burden of disease tells us about healthy years lost due to illness, injury, disability, or premature death. Prevalence tells us how common a condition is at a point in time. Incidence tells us about new cases. Each indicator gives one part of the picture. No single indicator tells the whole story. That is why, in Unit 3, students need to interpret health data carefully and combine it with an understanding of health and well-being, determinants, equity, and population groups. Australia's health status is shaped by many things. It is shaped by public health action, such as immunization, health promotion, food safety, road safety, tobacco control, screening programs, and disease prevention. It is shaped by the healthcare system, including Medicare, hospitals, primary healthcare, the Pharmaceutical Benefits Scheme, the National Disability Insurance Scheme, and health professionals. It is shaped by individual behaviors, including diet, physical activity, sleep, substance use, and help seeking. It is shaped by social and economic conditions, including income, education, employment, housing, social support, and access to services. It is shaped by environments, including neighborhoods, transport, climate, air quality, and safety. And it is shaped by culture, identity, inclusion, discrimination, and the degree to which people feel respected, connected, and able to participate. So when we say Australia's health status is generally high, we are making a broad statement. When we analyze HHD properly, we also ask, high for whom? Compared with whom? Measured by which indicator? And what variations are hidden behind the average? These questions help us move from simple description to deeper understanding. They help us see why data matters. Data can show where progress has been made. Data can show where inequality remains. Data can guide policy. Data can support health promotion. Data can help identify priority areas. And data can help us evaluate whether action is improving health and well-being over time. As you drift toward the end of this episode, remember that health status indicators are not just definitions to memorize. They are tools. They help us describe, compare, and explain the health and well-being of populations. They help us understand Australia's strengths, such as long life expectancy and a developed health system. They also help us understand Australia's challenges, such as chronic disease, mental health concerns, unequal access, and variations between population groups. And in an exam, they give you the evidence you need to write clearly. Describe the indicator, use the data, explain the meaning, link to health and well-being, and return whenever you can to the calm language of the study. Health and well-being is complex. Health status is measurable, but never complete. Australia's health status is generally high, but unevenly experienced. And every statistic points back to real people living real lives with different opportunities, different challenges, and different forms of support. That is enough for tonight. Let the indicators settle. Life expectancy, health-adjusted life expectancy, mortality, morbidity, burden of disease, trends, comparisons, variations, and the quiet skill of explaining what the data suggests. Sleep well. Steve will see you in the next episode.